Thrive by Design is on a mission to co-design inclusive digital innovation and improvement in health and care to support everyone to thrive. To do this, we need to tackle digital inequity in health. The World Health Organization defines health equity as the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality, and that health is a human right. The provision of health and care services for everyone is an integral part of supporting people to attain their full potential for health and well-being. And since 1948, we have had a National Health Service which provides a comprehensive service for all, free at the point of contact, paid for by our taxes. Access to health and care services are important, but 90% of what affects our health and well-being are socio-economic factors. These include our surroundings, education and skills, housing, the food we eat, our money and resources, transport, family, friends and communities, and work. From applying for a job to contact with loved ones, every factor of our health and well-being has been affected by digital transformation. It is estimated that the digital transformation of our world has been accelerated by several years as a result of the pandemic. This means if we are not able to use digital technology, we don't have access to many of the factors that affect our health and well-being. Health inequities are systemic differences in the health status of different population groups. These inequities have significant social and economic costs to both individuals and societies. We've adapted the World Health Organization's definition of health inequity and framed it in a digital context, and so would define digital health inequity as where the digital transformation of health and care services and wider society is exacerbating the systemic differences in the health status of different population groups. These inequities have significant social and economic costs, both to individuals and societies. Concerns about the digital divide have been particularly acute during the COVID-19 pandemic, as the internet and digital devices have played an important role in allowing people to access services, attend medical appointments, and stay in touch with family and friends. Digital exclusion may make it more difficult for adults to access these support services, medical appointments, and various welfare activities. There are currently 14.9 million people who are not easily able to use digital in the UK. These people are more likely to be older, on lower incomes, and to be disabled. These people are also more likely to need to access health and care services. Throughout the pandemic, and in partnership with NHS England and Improvement, and a range of other national and local stakeholders, we have carried out primary and secondary research focusing on digital health inequity. This has included literature reviews, surveys, interviews, and discovery workshops. We have listened to people with living experience, including from seldom heard communities who are likely to be experiencing digital health inequities, and people with learnt experience from across sectors, including clinicians and other frontline workers, policy and senior decision makers, digital practitioners, and other stakeholders. Our research shows that there are a complex set of interrelated factors and barriers of digital health inequity, which, in an uncertain and turbulent world, can change over time for both people and systems. We have grouped the factors into 3 categories and framed these as questions. What is happening in my life? What is my current digital capability? How inclusive are the health and care services that I need? The deep root cause of digital health inequity, in a nutshell, is poverty of income and resource, poverty of skills and motivation, and poverty of trust. As you can see from these factors, this is a complex system-wide problem. So when looking for the solution, we should be approaching it from a system-wide perspective and be co-designing the solution. Our research has shown us that we often accidentally design exclusive rather than inclusive digital transformation. Digital health inequity has multiple, interrelated, and changing factors. It is a complex and systemic societal problem and will not be fixed by short-term, single-focus projects. Digital health inequity needs to be tackled at a system level through multi-sectoral partnerships which recognise the value of cross-sector working, where resources are pooled and relationships of shared understanding, trust and responsibility are built. This is a complex and deep-rooted issue, and it's also one that needs urgently addressing. Our research suggests local systems can start by going where the energy is, starting somewhere and starting now. If you want to tackle digital health inequity and would like to find out more about our Inclusive Digital Transformation Social Change Programme, visit our website or future NHS